Gormagiv, Christian Higgin Irish Launcher. First priority question in the name of Deputy Billy Keller. I'll call the Minister of State. Oh, sorry, I beg your pardon. I thought, question number 1 is in the name of Deputy Billy Keller. I call the Minister.
Yeah, in the region of €500 million of these savings will be achieved through cost efficiencies and separately through reorganisation under the Public Service Agreement. The majority of savings will have no recourse to frontline activity. However, 2013 will be a very challenging year and requires taking a number of tough measures to ensure the most vulnerable are protected. The following is a summary of measures to be taken by the Health Group of Votes in order to adhere to the 2013 expenditure ceiling. A reduction in the cost of drugs and other prescribed items, €160 million. Increase the DPS threshold to €144 a month, is €10 million. Increase of the prescription charges for medical card holders, €51 million. Reduce professional fees, €70 million. Other changes to primary care schemes, €32 million. Pay-related savings, €308 million. Increased generation of private income, €65 million. Savings on the Department's own vote, €60 million. Procurement measures, €20 million. Other measures, €5 million. Total net savings, €781 million. The Department of Health's own vote has been reduced by €90 million. €30 million transferring to the HSE and €60 million in savings. Even allowing for additional expenditure related to the EU presidency, there will be a reduction in the Department's administrative budget. There will be savings on the National Treatment Purchase Fund, and €25 million of its budget will be transferred to the HSE. There will also be a range of further reductions, including reductions in funding for health agencies.
Chuck the Billy Keller.
Yeah, I suppose the Minister would forgive me for raising this particular question in view of the fact that we had to vote through an estimate last week. And I know the Minister outlines that it is a very small percentage and that overruns are the norm in terms of the health service because they're demand-led. But clearly, Minister, I think we want to set off in 2013, not on the way we set off in 2012, in terms of making sure that we actually have a pathway to the end of the year. Because the last thing we need to do is to have a situation where, because of the cutbacks, and you're paring closer to the bone the whole time, and we accept that, but that at least there's identifiable savings that can be achieved and that are realistic. And if they aren't being achieved, in the first half of the year, well, then we have a problem immediately. And I think rather than delaying and prevaricating, would the Minister not agree that it would be timely that, in the event of, for example, the Public Service Agreement and the cost efficiencies, but in terms of pay, like if you're talking about a reduction in those core areas, you will need agreement, otherwise you're going to have confrontation. And I'm just wondering, have you had any discussions in terms of with the trade unions and others? Because, for example, recently you announced that graduate nurses will be taken on at an 80% cost of a qualified nurse that they're working next to. And I'm just wondering, are we beginning now to ask the generation behind us that had no responsibility for anything to carry the can for everybody?
Thank you, Deputy.
And I just genuinely believe that that is a distasteful approach that we're beginning to see evolve. And would the Minister accept that we need to be clear that everybody must carry the burden, and certainly asking graduate nurses to carry the burden is something that I would find unacceptable, regardless of whether or not it is identified as a saving.
Well, as the Deputy knows, the service plan will be produced. It has to come to me within 21 days with the estimates. That means Stevens' day, so de facto, I suppose, the end of this week. We've had a number of meetings about it, the last one last night. Myself and my colleagues, Ministers White and Minister Lynch, have been actively engaged in this process. And like you say, we want a very transparent methodology this year that we can measure what's happening. Now, last year I did ask that there would be 2 weekly and monthly reporting of financial parameters, and that did not happen. It is going to happen this year. We've also identified through several reports, the latest being the Ogden report, the deficiencies that lie within the HSE in terms of its financial reporting mechanisms. And the PA consulting report set about to confirm that, but to identify the remedy to it. And we have done that. And we have put in place 6 individuals, senior, experienced individuals in the financing area. I think it's a shocking thing to tell the Dail that only around 10% of the people dealing with the finances of the HSE have specific financial training. Is it any wonder we find ourselves in the situation we have found ourselves in?
Thank you, Minister.
So, I want to mention specifically the issue around the job bridge for nurses. I think this is an excellent development. I think it's offering the opportunity for nurses now who've trained here to stay here and continue their training. And it will offer them an opportunity to further their experience. In fact, I want to see similar opportunities afforded to people who've studied physiotherapy, got 550 points and they're leaving, done 4 years in Trinity. And many of them can't find a job when they come out, and they're not able to set up on their own, as it were. But given a couple of years' experience, they would be well fit to go into primary care, where we need them, and need them badly.
Just have to call Deputy Keller and
Okay,
come back
sorry,
to you.
great,
Deputy Keller, we'll just 6 minutes per
I
question.
hope you enjoyed the reading over the Christmas sandwiches on St. Stephen's Day, or the turkey sandwiches on St. Stephen's Day. But, like, clearly, Minister, what happened last year was very identifiable early on, as early as March, April, May, June. And while there may have been overruns in terms of the delivery of services, the clear failings were in the implementation of the savings. And like that is the concern that we would have again. That is, the savings element was not, and that was primarily, it was a political accountability, administrative in terms of the Department of Health in bringing forward legislation, etc.
Thank you, Deputy.
So certainly we would be very concerned that if it's not identifiable early on and a clear pathway laid out in the service plan, and that there's alarm bells ring early on, that action will be taken so we don't have people outside government buildings like we had in September.
Deputy across, and in fact, you know, I think what I want to say here is something that needs to be said. For far too long, we had too many people who were quite happy to describe what the problem was, but failed to do anything about it. So we had earlier this year, yes, people saying that there was going to be an inability to keep the budget, and they alluded to two instances in particular, the drugs issue and the insurance issue. Now, the insurance issue was dealt with. The drugs issue has been dealt with comprehensively, but perhaps a little bit later than we would have liked. But the reality is that if you strip, even if those two things happened, there was still going to be a huge overrun in the GMS and the PCRS area. So, in my view, we are now moving to the area of transparency and accountability, so that we now, not alone do we let people know where the problems are, we tell them what we're going to do about it. It's not good enough for people to simply come and describe what the problem is and throw their hands in the air when they're supposed to be managing it and dealing with it. And that's what we had in the past. But we will have that no more. I just want to say, you know, in relation to the LRC as well, that, you know, we've had major changes in terms of how consultants are going to operate, and that's been bedded in at the moment. And that gives a lead to the other care professionals in relation to the changes in work practices that we will expect of them as well, in order to make our health services competitive and affordable and efficient, so that everybody who uses them can access them as they need them. Thank you.
Next question. Is Deputy White taking the next question? This is one on the home health powers. Deputy Quayle on the question. So I call on the Minister.
Sorry, Deputy Quayle, I'll take this on behalf of Minister Lynch, who's tied up in the Shannon at the moment on an equality issue. The government policy is to support older people to live in dignity and independence in their own homes and communities for as long as possible. This, as reflected in the HSE Service Plan 2012, includes various community-based services such as mainstream home help, enhanced home care packages, Meals on Wheels and Dail respite care. These services meet the preferred wishes of many vulnerable older people and also reduce pressures elsewhere on the wider care system. The demand for these services will increase as the demographics and complex needs of older people change. The HSE has developed various operational initiatives to improve nationally its approach to all relevant aspects of its home support services. These include new guidelines for home care and a new procurement framework for approved agencies providing services on its behalf. While ongoing developments have been designed to standardise and maximise the use of limited resources, they also promote quality, safety and equity for both providers and care recipients alike. Around 100,000 people, that's 20% of the population over 65 years of age, receive some form of HSE community-based supports each year: home care, daycare, respite, etc. The outturn for the 2012 target for mainstream home help I can give some figures, but perhaps I'll give them over to you later if you like, or I'll read them now if you wish. In 2006, we provided 10.8 million hours. In 2012, it was 10.7. Well, the target is 10.7. In 2011, it was 11.1 million hours. The number of clients benefiting at the 31st of December each year has risen from 49,578 in 2006 up to 54,000 in 2007, 55,000 odd in 2008, in 2009, 54,000 in 2010, 50,000 in 2011, sorry, 50,986 and 50,000 in 2012.
I have to interrupt the Minister and the rest of
The funding has risen, I think this will be important, from 185 million to 211 million last year to 205 million this year. And it's our intention that we would maintain the budget for 2012 and 2013.
Chuck the Quavy Nuclear.
Minister, in her pre-budget statement, Minister of State Kathleen Lynch made her post-budget statement, I should say, a vague claim that there is a commitment on the part of government to restore home help hours and home care packages. Now, you yourself, questioned by me at a recent health committee meeting, indicated that you intended to restore funding to the 2012 level in 2013. Now, my core objective is to establish whether or not the hours that have been cut from people across the board are going to be restored. And that's the critical question that has not been answered. Funding levels, you have indicated, will be restored to the 2012 level. Is that the position that applied at the end of 2011? Or is it post the loss of 500,000 hours as of January of this year? Or is it only in relation to the 450,000 hours that came in on the back of your 130 million cuts announced at the end of August? I think it's very important. The overwhelming body of people out there who are affected by this want to know their personal situation. I have instanced to you in the past the 94-year-old man in my own constituency whose 11 hours per week were cut to 5. The 82-year-old woman acutely ill in Cork with clots on her lungs, who requires oxygen on a 24-hour basis, and her 4 one-hour home help visits per week were cut by 15 minutes per day, and her evening supports, her night visits, were taken away altogether. And lastly, just to instance, in Galway, a mother completely robbed of her 5 hours a week, where she tries to provide 24/7 care for her severely disabled 6-year-old son. These are the cases, Minister. It's not just about, the level of resourcing. It's about whether or not the hours that have been taken from all of these deserving people will be restored. Can you give us a categoric assurance that that will be done as early in 2013 as possible?
Call the Minister.
I'd just like to restate for the information of the House that the budget for 2012 is going to be restored for 2013. Clearly, individual cases change and their needs change. So to say that every single individual hours will remain the same next year would be utterly inappropriate. Some people will need more hours and other people will need less as their situations change. And indeed, when it comes to the home care packages, which are different to home care help, the intention always was that these packages would change and would rotate. I mean, the classic situation is the 70-year-old gentleman coming out of hospital having had his hip done. His wife might have arthritis, find it very difficult to look after him in the early stages. He would have a nurse visiting, he would have physiotherapy, he would have home help. But as he progresses from 2 crutches to 1 crutch, perhaps the nurse no longer needs to go, and then 4, 5, 6 weeks later, he won't need the physio either, and the home help hours can be reduced. That is the nature of the service that we provide. It is to provide the service to the right patient at the right time, at the right place, and to monitor their progress. And indeed, to monitor sometimes their deterioration. I fully accept that. So it is our intention to restore the budget. I'm very pleased about that. That doesn't mean that I am not going to seek more efficiencies from that budget and look long and hard at and have asked the HSE to examine why there seems to be some differential between the payments made to some private providers versus the public providers.
I can only interpret from what you're saying, Minister, that you intend restoring the budget on a funding level to the pre-30th of August position, and that one can only presume that while you're not saying it clearly, that the cuts announced in Budget 2012 back in December 2011 will stand. Would you not accept, Minister, that the home help hours, the home supports that have been provided, are among the most cost-effective within the broad health service, that we make phenomenal savings in relation to care in the home for our people who need that support, and that any deterioration, any diminution of that support and service is going to lead to an earlier dependency or earlier demand for access to nursing home or other such institutional support, with all of the consequential additional costs that that will entail. Can you not look within the overall budget and find what is required in order to restore the situation to the pre-January 2012 level? That would be to restore, one would hope, the 950,000 hours that were taken from home help throughout 2012.
Thank you, Deputy.
And in the end of the day, Minister, it is about the number of hours and the hope and expectation of those many, many people who have been hurting and hurting greatly over this past period of time. Will you take the opportunity?
Minister to final reply on this question.
Thank you very much. I'll ask Councillor. I'm very aware of the value of home help and home care and the need to support people at home. I know of nobody who wants to go into long-term care before they need to. I'm equally aware that in our hospitals, because of the manner in which they're run, sometimes people, after they've finished their acute phase of care, are left in a hospital bed because there's nowhere else for them to go. Now, we brought in a transitional care programme which will address that, where people will be admitted to specialist wards who are older and frail, have their medical conditions addressed urgently, and start their rehabilitation immediately. If that's likely to last 4 or 5 days, they'll be transferred to another facility in the community where that rehab can continue from anywhere up to 6 to 10 weeks. Following that time, or if during that time it becomes obvious that they need long-term care, they'll be able to go to a transitional long-term care facility until the place of their choice becomes available. This will, in a great way, alleviate a lot of the congestion in our hospitals caused by delayed discharges. But in the community particularly, there's going to be no case, and should be no case, and I've issued this instruction very clearly to the HSE that people must be assessed before their hours change. And if they're to change, the assessment should never be such that it results in a person ending up in an institution, whether it be a nursing home or a hospital, as a consequence of the reduction in home help or home care package hours.
Question 3 in the name of Deputy Mick Wallace, and I call the Minister.
Thank you, and to thank the Deputy for raising this. Statistics on the causes of death are based on civil registration and compiled internationally by the World Health Organization. In the most recent World Health Statistics Annual Report 2012, Ireland had the 13th lowest rate of maternal mortality out of 178 countries reporting data. Maternal mortality is a rare occurrence in Ireland. It must be understood that since there are usually fewer than 5 such deaths per year, rates can appear to fluctuate significantly from year to year, especially if you look at it in terms of a percentage. So, for example, an increase in deaths from 2 to 4 in a given year would lead to an apparent 100% increase in the maternal mortality rate. Because of this, reports based on data from different years can appear to be contradictory. It's generally recognised internationally that official vital statistics can result in an underestimate of maternal deaths. In particular, indirect obstetric deaths resulting from previous existing disease or diseases which develop during the pregnancy may be missed in the official statistics. For this reason, Ireland established a confidential maternal death inquiry system in 2009. In doing so, it linked itself with the United Kingdom's confidential maternal death inquiry system, which has been acknowledged as a gold standard for maternal death inquiry in recent decades. It's important to emphasise that if data from a confidential maternal death inquiry is used, the results can only be compared with the results from other similar inquiries. The recently published report of Ireland's confidential MDE, or maternal death inquiry, for the period 2009 to 2011 cannot be compared with civil registration-based rates for other EU countries which do not have MDE systems. Excuse me. Comparison with the UK's MDE for the period 2006 to 2008 showed Ireland with a rate about 30% lower than the UK. Again, however, caution must be exercised in interpreting the data, since even when aggregating 3 years of data, i.e. 2009 to 2011, numbers of deaths remain small and the rates will be subject to significant fluctuation.
I have to interrupt the Minister. The rest of the reply will appear with the official report. Deputy Wallace.
Thank you, Corda. Minister, I suppose I accept that I mean, the numbers are very small, and I realise that a few numbers can change the percentages dramatically, given that the numbers are so low. And I do think it's phenomenal that the numbers are so low. I have 4 kids, and I was at the birth of the 4 of them, and I find it hard to believe that there isn't more problems. And it is fantastic the numbers are so low. But this confidential maternity death inquiry does put the numbers double what the Central Statistics Office put, and it says for the years 09 and 10, there were 149,000 maternities in Ireland. 12 were maternal. There were 12 maternal deaths. This gave them a maternal death rate of 8 per 100,000 for the combined years of 09 and 10. Data on the number of maternities for 11 are unavailable at the time of writing. Then the rate was double the CSO figure. But in the recommendations, Minister, of the report, it's the first one, a question on pregnancy status at time of death, similar to that on the medical death certificate, should be added to the coroner's death certificate. And the second one that I would see, they have 6 of them in total, but the second one, the interpretive services should be developed to ensure that the care of any patient is not compromised by lack of communication and any misunderstanding. And you'll be familiar with the case of the African woman Bimbo Onanga, who died in March 10. Her partner commented that the hospital staff would not listen when he repeatedly warned that her condition was deteriorating. And
Thank you, Deputy.
it was reported that it's been reported 75% of maternities in Ireland in 2010 were women of Irish nationality, but significantly 40% of all maternal deaths identified in 09-11 by MDE Ireland occurred in women who were not born in Ireland.
Come on, I have to call the Minister, and I'll revert to you, Minister.
Obviously, those statistics would have to be further examined in terms of how many of the births were to women who were of non-Irish descent in the first place. But clearly, if there was a disparity, that would be of concern. I'd have to agree with the Deputy. I mean, communication is absolutely essential. I mean, it's the cornerstone of clinical practice. If you can't hear what the patient is trying to tell you, your chance of having a proper diagnosis and proper treatment and best practice is pretty minimal. So that's an area of concern always, and certainly we need to be very vigilant on that. And in fairness to the Irish College of General Practitioners, they were the first college to introduce a communication module to their training. And I believe it should be in all training of all health professionals, not just doctors, but also nurses, physios, etc. And language barriers and cultural differences, make a huge difference in this area. Even those who speak English as their normal language, different expressions have entirely different meanings in different cultures. And I could give you some examples which might amuse the House, but mightn't be really proper in the public place. So in other words, not to make light of this, different things mean different things to different people, even though it's the same words used. So the cultural issue is really important here as well, and I accept what the Deputy is saying vis-à-vis the concerns around communication.
Thank you, Minister. Deputy Wallace, briefly.
I understand in England, Minister, if there's a maternal death, there's automatically an inquiry into it, which we don't have here. And the African woman in question, Bimbo Onanga, is getting an inquiry now, but 2 years after her death. So, I mean, would the Minister consider putting in place a structure in Ireland where we would have an automatic inquiry in the case of a maternal death?
Come out, final line of them.
Deputy, without being absolutely categorical, I mean, in my view, from what I understand, there is an inquiry whenever there's a maternal death, and I know there were 2 in one maternity hospital 2 days in a row earlier this year, which is something that hasn't happened for decades. And yet, 2 different teams involved, 2 different theatres involved, and ultimately both investigated, found to be of different natural causes, unrelated to the specific practice in each case. So occasionally you get these bizarre coincidences in terms of the time of these tragic events. But there is an inquiry any time there's a maternal death, to my knowledge. And also the MDE, the Maternal Death Inquiry System, has requested that the coroner's courts always report to them if any of their inquests involve a woman who's been pregnant.
Come out, question in the name of Deputy Billy Keller and the Minister of State.
Thank you, Elias Corcola. Under the provisions of the Health Act 1970, eligibility for health service in Ireland is based primarily on residency and means. There are currently 2 categories of eligibility for all persons ordinarily resident in Ireland. Full eligibility, which is the medical card, and limited eligibility, which is everybody else, essentially. Full eligibility is determined mainly by reference to income limits and is granted to persons who, in the opinion of the HSE, are unable to provide general practitioner, medical and surgical services to themselves and their dependents without undue hardship. There is no automatic entitlement to a medical card for persons who have cancer. There is a provision for discretion to grant a card in cases of undue hardship where the income guidelines are exceeded. The HSE recently set up a clinical panel to assist in the processing of applications for discretionary medical cards where there are difficult personal circumstances. There is an emergency process for a person who is terminally ill or in urgent need of medical attention and cannot afford to pay for it that provides a card within 24 hours while the normal application process is completed. Details of this procedure have been made available to all GPs and social workers. Such applications can be initiated through the local health office, whose manager has access to a dedicated fax and email contact line to the Primary Care Reimbursement Service, the PCRS. Once the medical condition is verified by a GP or a consultant and the required personal details are provided, an emergency card is issued to that person for a 6-month period. No means test applies to an application in the case of a terminally ill patient.
Chuck the Billy Keller.
Yeah, thanks, Minister. I suppose at the outset, I just want to say that last year I raised this particular issue in regard to one individual who was terminally ill and subsequently passed away, and the system did respond, in fairness. But the reality here, Minister, is quite different to what you say and what is happening on the ground. This clinical panel that assesses medical cards or medical card applicants simply must be very strict, because what is happening is the rate of refusal for people, particularly people who have cancer. And I'm around this place 20 years, Minister, and I always believed that if you had cancer, you applied in the normal way, but it would be granted you discretionary based on medical need. Now, what is happening here is that is not the case any longer. We now have cases, Minister, where a woman has had a mastectomy and still cannot access a medical card. Now, I find this bizarre, to say the very least, that we now have a situation where, the state, the minister, the HSE is saying one thing, and what is happening on the ground is completely at variance.
Thank you, Deputy.
And I just think that we have to, like the Irish Cancer Society said quite clearly, they're now finding large numbers of people who are cancer patients who are applying to the Irish Cancer Society for support to assist them in accessing treatment. And we now have hospitals hunting them down for €75 a go every time they go in for chemotherapy. There's just something very barbaric on this, Minister.
Thank you,
and I would
Deputy.
ask that you would look at this in the context of the service plan for next year.
I call the Minister of State.
Well, the issue in relation to the inpatient charge is, although it's related, it's a slightly different issue to the one that's raised in the question, which relates to the making available medical cards to people on a discretionary basis, and discretionary basis on the basis of a medical condition, and obviously that has to be set out and there has to be a process put in place, because there's never been an automatic entitlement to a medical card based on, even where a person has a debilitating and deeply stressful situation where they find that they have cancer. Our system doesn't provide automatically a medical card to such a person. There has to be an application made, and the application should be made, and it should be dealt with, and I and the Minister would expect the application to be dealt with sensitively and to be dealt with to be expedited. And certainly, if there was any sense in which that was not occurring, that would give cause for concern. But there's no automatic, I have to emphasise that again, it isn't an automatic entitlement. Application has to be made, it's done on the basis of the medical evidence, and it should be expedited. And certainly would be my view that it ought to be expedited.
Deputy Keller.
Minister, you see, the €75 is slightly linked, because if you had a medical card, you wouldn't have to pay the €75 in the first place. And I do accept that there's never been an automatic entitlement to a medical card. But what is happening quite clearly is that this clinical panel has raised the bar so high in terms of assessing entitlement based on medical need. And clearly, that's what's happening, that they just cannot qualify because of this clinical panel raising the bar so high. And I genuinely believe, of all things, you should look at this, because it is completely at variance to what's being said in the Dáil in terms of cancer patients not being able to access medical cards when they go through the formal process of applying, the clinical panel assessing medical need, and they're still refusing. I just can't countenance at this stage, and I do accept that there was never an entitlement. But I think almost every deputy inside here would have told you that over the years, if you had cancer, you would get a medical card on this medical assessment and need. And that's not happening anymore, and now they're being charged €75 to go into a hospital for chemotherapy treatment. There is something very, very sad if that's the case.
Come out with the final reply.
At the risk of, because obviously it is a sensitive area, at the risk of irritating the deputy, I have to repeat again that it has never been the case. It has never been the case that there was an automatic entitlement to a medical card. And if you know, medical grounds. Yes, and that is the case. And certainly, if there are individual cases, and I've no doubt that just in the normal run of events, that where applications are made, and if the deputy certainly is aware of particular instances that he wishes to draw to our attention, certainly they'll be addressed. But we can't give hand on heart an absolute guarantee that in every case an application is dealt with in an expeditious way, but it should be. I don't accept, and it's certainly not clear to me, that there's been the sort of fundamental change in practice or approach that the Deputy says there has been. If there are particular individual cases that have, as it were, fallen through the cracks in terms of the application process, if they're brought to our attention, they'll certainly be addressed.
Kishtakuig is in the name of Deputy Luke Flanagan, and I call the Minister of State. Kishtakuig.
My department has been informed by the Irish Medicines Board, the IMB, that it is in receipt of a market authorisation request from a manufacturer under the EU mutual recognition procedure for a medicinal product containing cannabis extract. This product is indicated for the relief of symptoms of spasticity for people with multiple sclerosis. Under the Misuse of Drugs Act 1977, the manufacture, production, preparation, sale, supply, distribution and possession of cannabis or cannabis-based medicinal products are unlawful except for the purpose of research. My department is currently examining how authorised cannabis-based medicinal products for patients suffering from multiple sclerosis may be legally prescribed by medical practitioners and used by patients for the treatment of MS in Ireland. In that respect, department officials have been engaging with experts to identify how best to legally prescribe authorised cannabis-based medicinal products while maintaining existing controls on cannabis and cannabis substances. While the legislative amendments required can be made by means of statutory instrument, the legal issues nevertheless are complex. The matter is being progressed as quickly as possible in my department, and it is hoped to bring forward legislative proposals in early 2013.
Luke Flanagan.
That's good to hear that you're bringing them forward in early 2013. We now have a situation where 22 separate national authorities in Europe and around the world have granted approval for Sativex and recognise the important benefits it provides to MS patients with spasticity. Ed Holloway, Head of Care and Service Research at the MS Society in Britain, said that the MHRA has already looked at the evidence surrounding Sativex and has decided it is safe and an effective treatment for spasticity. Otherwise, it would not have been licensed. So I think at this stage, well, around Europe anyways, and in other countries, it has been shown that this is an effective treatment. It isn't the cure-all that some people say it is, but it does help people. And really, what I'm asking here today is that this be done as quick as possible. And when you say that you're going to do this in early 2013, that you do it, because I have, at this stage, more and more people coming to me about this issue. And one particular man told me a very sad story about how he is forced to purchase cannabis of the type of people who shot Veronica Guerin, and I prefer if the money didn't go into their hands, in order to alleviate some of these problems. And according to this man, he no longer has to wear a nappy or a diaper when he uses the substance, but he found out someone in the north who was getting it, and he acquired it illegally and used it until it ran out. And after it ran out, he found that he had to go back using the nappies again. Now, look, science isn't based on anecdote, and I hate to see people doing it, but this person sees clear benefits out of this, and the idea that it would go on for much longer, you know, it just would be unfair. And I also want to point out as well, just one other thing. I would be well known for campaigning to legalise cannabis for recreational use. This is nothing to do with it, and I'd hate anyone to think I was trying to piggyback on it, because that would be disgusting, to be quite honest. So this is a separate thing.
He raises a very fair point, and there's no undue delay in relation to this. I was briefed on this matter when I became Minister of State. The matter is progressing. We have our own processes in this jurisdiction, though we can't rely on the licensing systems that are in place in other jurisdictions, although we can have regard to them, but we do have our own processes. And I will say that I agree with the Deputy, just finally, you know, that I and the Minister and the Department would absolutely be concerned to expedite the availability of any product that would give relief to persons suffering pain in the way that the Deputy has described. But we have to do this matter properly, and we will do it properly, and we will expedite it.
Briefly, Deputy.
Very briefly, the people who are contacting me will be waiting with bated breath for this to happen. It's something that I would like to have seen happen a long, long time ago. And I would also suggest, because I'm not a medical expert and the Senior Minister is, that maybe have a look into the claims by some people that it has positive impacts, THC, when it comes to treating cancer. I've seen and I've read a lot of stuff about it. I'd be very slow to shout about it, because my own mother died of cancer, and the last thing anyone wants is to be given false hope. But if there was anything in it, I'd be very interested to see, maybe if you could have a look at it and see, and tell me what you think of it maybe down the line.
Thank you, Deputy. Do you have Minister to add on?
You know, we have the very best technical advice available to us in the department and outside. And certainly, those kinds of issues can be reviewed as they arise. But in relation to the specific issue that the Deputy raised, we've given the response, and we are moving on.
We now go on to other questions. Same time limits apply. And question number 6, Keshta Shea, is in the name of Deputy Alan Farrell. So I call on the Minister.
The prevalence of overweight and obesity has risen steadily in recent times, with 61% of Irish adults now overweight or obese. The WHO now calls the alarming speed with which obesity has increased in recent decades a global epidemic. The recently published report, The Cost of Overweight and Obesity on the Island of Ireland, funded by Safe Food and conducted by the University College Cork, provides reliable figures for the annual economic cost of weight-related ill health here in Ireland. Initial findings estimate the annual cost of overweight and obesity in the Republic of Ireland to be around €1.13 billion. The direct healthcare costs are €398 million, or 35% of the total costs. This figure includes hospital, GP and drug costs. In addition to this, 2/3 of the economic costs were indirect costs and reduced or lost productivity and absenteeism, and these amounted to €728 million. These figures show that the extent of the problem is higher than the extrapolated figure used in the 2005 National Task Force on Obesity report of €0.4 billion. The UCC study shows that almost 10%, or 37,341 years of life lost, are due to overweight and obesity. The burden of disease from overweight and obesity combined account for an estimated 2.7% of total health expenditure. This Safe Food funded study is particularly timely given that obesity is a major health problem in Ireland of itself and contributing to other chronic diseases such as coronary heart disease and type 2 diabetes. Irish studies have shown that 2 out of every 3 adults are overweight or obese, 1 in 4 primary school children and 1 in 5 teenagers are overweight or obese. Of particular concern are the results of the recent Growing Up in Ireland survey, which found that in children as young as 3 years of age, 1 in 4 are overweight or obese. As Minister for Health, I have made overweight and obesity a public health priority and have established a special action group on obesity, whom I meet with regularly to progress the obesity prevention agenda. It is recognised that alone, no single initiative will reverse this growing trend, but a combination of measures should make a difference. For this reason, the Special Action Group is concentrating on a range of measures, including actions such as calorie posting in restaurants, which I have asked the Strategic Action Group on Obesity to prioritise as one of the key initiatives that will have a positive impact in addressing the problem of rising levels of overweight and obesity, and as a means of educating the general public on the calorie content of food portions.
Also, that's the reply will appear in the official report. Deputy Keller had indicated.
Just very briefly, Minister, we had some statistics presented to the Health Committee some time ago on this particular issue. Mr O'Shea, consultant with expertise in this whole area of diabetes and obesity as well, has said that we are now living and sitting on a time bomb effectively. In fact, he went further and he said it has gone off and the carnage is around us already, and that we have to act very promptly. And I just believe that we have to be very forceful in our decision-making process. Some of it may be unpopular in terms of policy. We need to look at the whole area of taxation for discouraging the fizzy drinks or the high sugar drinks, the whole issue of exercise, calorie counting, and making ourselves very aware on a national basis about health. And if you look at other countries that have tackled this head-on, for example, Australia and others, they have become almost obsessed with health. But they have shown amazing results in a very quick period of time. And you said before, Minister, it struck with me like that, you know, we owe it to the generation behind us. We could be the first generation that are burying the people that were born after us. And it is really incumbent on us to not only extrapolate from the figures, but to do something about it. And I would just urge that every possible measure will be taken. I know you have a special task force set up. The Oireachtas Health Committee would like to play its part, but I think broader society needs to be encouraged and cajoled by policy. Some of them may be unpopular, some may need tax hikes, others may need a change in mindset. But if we don't do something, as you said, we'll be burying our
I have a lot of interest in this question. So, Deputy Quillan, could you ask with the same, and we'll come back to the other 3 deputies then. Deputy Quillan.
Back in February, you told us here in the Dáil that there would be a voluntary code that would be monitored over a period of time, and that in the event of non-compliance, or if it didn't bear fruit, that you would actually legislate. Now, I believe that a lot of the focus in relation to this has been on restaurant menus, where I believe it should be directed is on the foodstuffs that we buy in the supermarkets, what we buy in our local convenience store, and what we buy in fast food outlets, where across all of those 3 there is a much greater danger and certainly a greater lack of awareness of what it is we're actually intaking as human beings. Minister, what is the update in relation to the monitoring of compliance in relation to this voluntary code? Are you in any way satisfied that progress has been made? Will you look at expanding it into the other areas that I've suggested? And, you know, at what point will you make the decision as to whether or not legislation is required?
Thank you, Deputy Minister. And I'll call the other deputies after that, in those 2
Thank you very much. I think you're quite right, last Count Cola. There is a major interest in this because, as Deputy Kelleher rightly points out, you know, I've said in the past, and I think we all believe it now to be true, that we could be the first generation to bury the generation behind us with the epidemic of obesity and the consequent epidemic of diabetes, type 2 diabetes, something that I never saw when I was practicing 20 years ago in anybody under the age of 30. Now you see it in teenagers. It's quite scary, and it is related, and there's no question. I think too, as somebody who's had an interest in this area for a long time, every second person that had obesity in my clinic, you know, was unaware of it. And I mean, if you're not aware that you have a problem, you certainly can't address the problem. So awareness is a huge part of that, and I thank Deputy Kelleher for his support in relation to striving to improve awareness. It is multifactorial, so it's not just health. It also involves justice and having safe places to exercise at night, an environment to have well-lit pathways that are safe, and education in terms of getting children to form a good habit in relation to physical exercise. And I know Senator Eamon Coughlin has been very much active in this area and just advising people about the value of fitness for fitness itself and how well it makes you feel. And there's lots of medical information and research to show that muscular activity creates endorphins, which are morphine-like substances that can make you feel well. So, you know, this area is one that needs a cross-departmental approach, and this is the first government to put in place somebody at the level of principal officer across health, education and children to promote this area and awareness. So, but all help is gratefully accepted, and all support will be gratefully accepted, and we will facilitate you in any way that you, with suggestions you have around how we can progress this. In relation to Deputy Quaylon's the monitoring, we are monitoring the situation. There is an appetite amongst many of the businesses actually to become engaged in this. I think part of the problem early on was they were a little bit concerned, I think even here in the Dail restaurant, about, you know, if it wasn't exactly 65 calories in the sandwich, would they be in trouble? That's not what we're trying to achieve here. We want people just to be aware of the sort of level of calories that's in a product, so that, you know, I know one instance of somebody going to a particular coffee bar and reaching out for the bun, and when they saw 400 calories on it, put it back again. And I mean, that's really what we want. It's not about a nanny state. We just want people to be informed. They have a right to know what they do with the knowledge, then it's entirely a matter for themselves thereafter.
Thank you, Minister. I'm calling Deputies Flanagan, Deputy Wallace and Deputy Flanagan, Deputy O'Donovan, Deputy Wallace. Could I have your cooperation, please, for brief questions?
Yeah, you cannot turn on the radio without hearing about if we did something about the promissory notes, how much money it would save us. And it wouldn't actually save us as much as some people are claiming, about 1.3 billion. And we hear it all the time. But we hear 3.7 billion alcohol abuse is costing us. You say 1.13 billion obesity is costing us. 1.8 billion, I think there was a figure put out there on not doing enough exercise. And here we are every day of the week talking about the promissory notes. Very, very important. But it actually pales into insignificance in comparison to these. I'm just wondering, is there an actual figure out there that takes them all into account? Because obviously if you have 3.7 billion caused problems with alcohol abuse, obviously part of that 3.7 billion is included in the obesity figures, and they're kind of subsets of each other. I'm just wondering, is there information out there as to what the exact figure is? But I think the big problem is that for the first time in the history of the human race, bar the landed gentry and royalty in the past, it is actually possible, very handily, to get enough calories. And it was often said in my house that you wouldn't leave a whole lot of tins of dog food open for the dog, because they're so stupid, they'd keep eating them until they died. But as it seems to be the case that now that human beings in certain areas of the world have unlimited access to food, that we are a bit like them dogs, and we don't know how to stop it. So it is a big challenge. But one of the things that's never taken into account is that very few of us actually prepare our food. Now, while maybe you shouldn't eat a bag of chips, and there's a lot of calories in it, and ideally you wouldn't, but at least if you go out and buy the spuds, carry them into the house, peel them, make the chips, wash up the dishes afterwards, you're actually using up some of those calories.
Thanks,
but the problem is nowadays you have any amount of access to it, and you don't have to put any energy into getting it, and that's where the problem
Thanks,
lies.
Deputy. Deputy Donovan, briefly, please.
Thanks, thanks very much, Lieutenant Corley. Minister, I've raised this issue before with you in relation to, I suppose, a comparison between the number of people that will die, that we know at the moment, invariably will die as a result of obesity-related illnesses into the future, be it cancer or diabetes or heart disease or whatever. And I suppose if you contrast it to the manner in which we've addressed collectively as a state deaths on our roads through the people like the Road Safety Authority and under the stewardship of an independent person like Gay Byrne. And I put it to you, would you consider, as part of the multi-disciplinary kind of interdepartmental approach, to putting an obesity czar in place that would be essentially, I suppose, a figurehead in the sense of holding the government to account, but more importantly bringing the public with them and bringing younger people especially with them, because oftentimes, you know, we're viewed probably not in the best light in this House on a lot of issues, particularly in relation to issues that might affect society.
Thank you, Deputy.
But I think it might be something that is worth considering, putting somebody in situ that's respectable to everybody, as legislators and the public and children and people involved in this, to ensure that this is something, as the White House administration and the Obama administration have done with the First Lady in America, and they have gotten tangible results.
Thank you very
So would
much,
consider
Deputy.
that?
Deputy Wallace, briefly also.
That's from Carla. First of all, I think men should eat the spuds in their jackets rather than put them in the deep fryer. And with regard to your bun, Minister, I have a coffee shop, and I'd rather they didn't touch it than not going to eat it. But with regard to, given that obesity is costing so much money, over $1 billion, and in the last round of sports grants, there was an oversubscription of 10 times by sports bodies throughout the country. 26 million, I think, available at the time. You might have a word with the Minister for Sport that it would be money greatly invested if the state were to spend more on sport in order to fight obesity, because I can assure you there's none of the Wexford under 18s and 19s at the moment obese.
Thank you,
Wexford
Secretary.
youths.
We've ranged far and wide. Minister, I have to ask you to be brief as well. We're over time.
Well, Count Corley, that's because the issue does range far and wide, in fairness. And to pick up on the point made by Deputy Donoghue, I mean, it's certainly something I look at. I mean, I think having a focused individual like that certainly has merit. I think this issue, though, of public health and well-being, I think I want to say something in this House here, because I've said it elsewhere and I've said it to County Council health forums. You know, we have a responsibility in this House around this as well, because it's always more sexy politically to open a new wing of a hospital or an MRI scanner than it is to promote a new public health initiative. And we've been very poor in the past about actually supporting these things as politicians, and more paying lip service than actually paying for them, as it were. But every euro spent in prevention can save anywhere between 12 and 20 euro on treatment, and that's well proven. So, I mean, in relation to Deputy Flanagan's issues, I mean, I would agree with him that there's a huge amount of money to be saved here in terms of prevention. There's a huge educational job to be undertaken. There's a lot of vested interest, there's no question. I mean, I would like to see a situation where vending machines in schools only sold fruit and apples and water rather than what they currently sell, chocolate and crisps. Because, you know, you have to make the right thing the easy thing to do. And if you're hungry and all that's to be availed of is a vending machine that sells this sort of stuff, that's what you'll do. So look, I mean, I think this issue is one that's going to occupy our minds for a considerable time to come. I'm open to any initiatives that people have in their minds to talk to us, to submit to this, to SAGO, the Special Action Group on Obesity, and I'd look forward to your contributions. In relation to alcohol, which is an area that Minister White is particularly interested in and is progressing a policy on, you know, I want to see in that area too that not alone do they put the units of alcohol on the side of the container, but they put the calories on it too. Thank you.
Margaret, Kirsty shocked in the name of Deputy Mick Wallace. I call on the Minister.
I'll ask Count Corley, with your permission and the agreement that the Deputy will take number 7 and 12 together.
Agreed? Agreed. 7 and 12.
Okay. As the Deputy is aware, Professor Una Walsh, an independent researcher, was commissioned by the Chief Medical Officer in my department to draft a report in relation to the practice of symphysiotomy in Ireland. The report was conducted in 2 stages. The first stage is an independent academic research report, which is based on an analysis of published medical reports and research. The draft report contains information about how frequently symphysiotomy was carried out in Ireland and compares rates with other countries. The researcher experienced unforeseen difficulties in accessing information sources and as a result submitted the first stage of the report behind schedule in late January 2012. The researcher informed my department that this was due primarily to the challenges with accessing historical data from a time when records on the procedure were not routinely kept. The second stage in the research process involved the consultation process on the draft report involving patient groups, health professionals and in particular the women who have undergone symphysiotomy. The researcher is currently finalising the report based on the consultation, and it's also planned to have a peer review process. It's hoped that the report will be published early in the new year.
Lee McWallace. Yeah.
Councillor Corla. I'm just wondering, is the Minister aware that there are a number of inaccurate and misleading findings in the draft report? For example, that symphysiotomy was used mainly in emergencies, which is untrue. That symphysiotomy was safer than caesarean section in the 40s and 50s, which is also wrong. That doctors were not and are not legally required to obtain patients' consent to medical treatment, which, like other statements in this report, is nonsense. Does the Minister know that the vast majority of survivors of symphysiotomy refuse to cooperate with the so-called consultation process run by his department on the Welsh report, because, like the Finucane family, or under the Silver report, they see it as a whitewash? Would the Minister not do the decent thing, jettison the discredited report on yet another sorry chapter of institutional abuse in Ireland, and set up a commission of inquiry so that the survivors in their 70s and 80s can finally access truth and justice?
I call on the Minister. Yeah.
Thank you, Councillor Corla. Well, the Deputy Cross has made some statements there, which, I mean, certainly the idea that a consent isn't necessary for a procedure is utter nonsense. I agree with him there. Whether we're comparing the practices of today with the practices of 50 years ago and 60 years ago is an issue, and that's a difficulty. But one thing is absolutely clear: what we seek to do through this report is to find justice and to find closure for the people who suffered at the hands of doctors who performed these procedures, sometimes utterly unnecessarily. I mean, you know, the idea of symphysiotomy being performed, as they say, on the way out, when the child has already been delivered, to my mind, is outrageous. But, you know, I would like to allow this report to be finalised, the consultations to take place, and then come back with a solution that hopefully could bring closure on this issue for the women who have suffered as a consequence.
Thank you, Deputy
Corla. Minister, you've indicated sometime early in the new year. I presume that on receipt of the report, you will publish the report, that we will have the opportunity to examine its content. Could I suggest to you, Minister, that whatever the final Walsh report contains, that there is an onus and a responsibility on all of us as political voices to listen to the demands of the victims of this, as I have seen it always. You have disputed the view, barbarous procedure and related procedures of pubiotomy, that I believe we have to listen to their appeals, and their appeals cross a number of different possible processes of resolution. And I believe that the choice should be given to the women themselves. They are a never-reducing number. Since the last time, Minister, we addressed this issue here in this chamber, I know personally of, albeit a small number, but a number nonetheless of victims who have passed on from this life. And that is going to continue to be the case.
Thank you, Deputy.
It's very important, and I use the opportunity, you know, here we are, the last opportunity to engage with the Minister before the end of this year, to commit to providing choice. There will be those who will be happy to accept some form of redress, but there are many, many others again who want the opportunity and who feel that only by access to the opportunity of court process will they be able to fully vindicate their right to truth and justice. I believe that in order to facilitate a significant number of those, that the suspension of the statute of limitations, particular to that cohort of victims, will be required. And I ask the Minister, I'm not expecting a response in relation to either here this afternoon, but I'm asking him to reflect on that, and if he will keep an open mind, and hopefully in early 2013 provide that choice for that ever